We will go ahead and get started. I'm going to load these slides up right now. And thank you so much to everyone joining our webinar. We've already got a lot of people in, and I can see that. So thank you, thank you, thank you. We got neighbors. I'm from North Carolina, Charlotte, North Carolina. So is Don. And so we've got a lot of folks from North Carolina, Idaho,
Yes.
Wyoming, Maryland. So good to have you guys all in here today. So please keep, if you don't mind, share where you're from and your discipline. If you feel comfortable doing that in the chat, we would love that. I first want to start off and tell you there's 3 ways that you can talk to us in the chat. So there's 3 ways. The first way is going to be in the QA, which we actually see last, so I do not suggest. The second way is right in the public chat, and you're doing a fantastic job with that. And then the other way is going to be private messaging. If you have a question and you want us to answer it, but you don't want to share it with the group, not a big deal. Just send us a private message. So I am going to go ahead and get started. And welcome to today's webinar. We're going to explore some of the most urgent and often most understood issues affecting teens and self-harm, and kind of those compulsive behaviors that surround it, as the rates of adolescent mental health crisis really, it just continues to rise. Okay. And so there's clinicians that are involved in this. There's educators and caregivers that are encountering more and more young people that are engaging in this kind of repetitive self-injurious behavior that mirrors addiction-like patterns. And so we're really going to delve under the hood of that today and the underpinnings of self-harm, the way it can become habit forming, some red flags you may see, and also examine, most importantly, some evidence-based approaches for those. So thank you so much for joining us. The chat is just going wild, so that's fantastic. I do want to introduce our primary speaker today. He is absolutely wonderful. This is Don Morrison. He is an LCSW. He has over 20 years of experience in adolescent mental health, trauma recovery, crisis intervention. He's a dynamic speaker, and he is a sought-after educator because he has taught as well, and he has worked across. We've worked together in outpatient settings and like residential almost treatment centers, and then also, Don, you've had quite a bit of experience in school-based. You have your own practice. And I'd like you to share the name of that. And you've helped a lot of young people kind of navigate complex challenges of self-injury. And your work really emphasizes trauma-informed care and also DBT, right? And so
Yes.
you're very passionate about helping fellow professionals. And so I just want to let you take it over.
Absolutely. Thank you so much, October. So good to be here with you today, no doubt. And yes, indeed, we did work together. We had some great times there on that inpatient unit. So it was never a dull moment, but such a wonderful, wonderful experience. So it's good to be here with you today, and good to be with all of y'all today. Thank you for checking in. I'm here in the Mooresville area in North Carolina, in the Lake Norman area. And so y'all keep checking in, please, with us. Let us know where you're coming from, who's joining us today. And you know what? I like to throw in, let's start off the day with some good news. Share some good news. I don't care what it is. Share some good news with us today, because, we need to hear some good news. That's very important too. And of course, the reason why we're here today is to talk about how self-harm does become a bit, if we want to look at it through an addiction lens, it does become a bit of an addiction for our teenagers. So we're going to be looking at all of the aspects of that and breaking it all down. And hopefully we've got a lot to talk about in this brief 1 hour period of time. So we're going to hit the highlights of so many of these topics. But if there's anything that you guys feel like we should continue, October and I have discussed this. We're always open to continuation, because certainly with these topics, especially in delving into self-injurious behaviors and DBT and all those things, obviously we can do an entire semester with this kind of stuff. So definitely, today we're just going to hit some of the highlights. Then we want to hear from you about what more you would like to see about these topics, if at all, for the future, no doubt. So let's start, shall we, October? First slide here, we're going to talk about the learning objectives today, and these are pretty straightforward. It's like, of course, recognizing some of those emerging patterns and warning signs for self-harm in teenagers, understanding the psychological and behavioral drivers behind self-harm addiction. I think that any of us in mental health, we always want to try to understand the hows and the whys, and certainly we'll spend some time talking about that. Also applying evidence-based interventions to support our teens who are engaging in self-injurious behaviors. You know, I'm guessing that most of y'all at some point have heard about dialectical behavior therapy, or DBT. CBT, cognitive behavioral therapy, and other interventions have proven to be very helpful in working with this population. So certainly we'll spend a little bit of time touching on those. And then, of course, at the end, navigating the legal and ethical considerations when reporting self-harm in minors too, because that is certainly a consideration that we as clinicians have to take into account as we try to navigate sometimes these very complicated family systems, no doubt. October, next slide, please. And why does this topic matter? We'd love to hear too in the comments if you don't mind. Why are you guys here today to explore more about this topic? What about this topic is important to you as a mental health clinician? Obviously, we've known this for a while. Self-harm is rising among teens at alarming rates, and October is going to give us some numbers and some statistics here in just a second. But I think for what I'm going to do here, I think it's important for us to look at what is self-harm within this context. And if we're looking at it through this lens in particular, you've probably heard the term non-suicidal self-injury. That is the type of harm that we're focusing on today and trying to understand that type of self-harm. And usually when you hear the term self-injurious behaviors, let's do a little Freudian free association if you don't mind. What is the very first thing that pops into your mind when you hear self-injurious behaviors, or even a term like non-suicidal self-injury? What are some of the first things that pop into your mind? Let's free associate as we're chatting here if you don't mind. But I will say usually, and this is a bit of a stereotype, but there is some facts to support this. Usually cutting behaviors are what we think of when we hear self-injurious behaviors. And in October, I'm not seeing the chat. Is anybody, what are people responding to in the chat here? I'm just curious.
100% cutting, like not a lot of cutting. Pinching, we've got some pinching in there.
Absolutely.
Head banging, hitting, needing attention. So yes, definitely. And let's make it where you can see the chat.
Yes, please.
People are really active and it's absolutely wonderful. So
yes, here it is. That was a user error. I've got it now, no doubt. Thank you. And thank you all for sharing. Yes, absolutely. Picking, pulling hair, burning self. Absolutely. Absolutely. So obviously from your responses, you are very aware that self-harm can manifest itself differently for everyone. Each and every one of our clients are different. And if we're looking at them through a person-centered lens, recognizing that they all have their own individual specialized needs. And you know, I think like you shared with some of the examples, cutting tends to be the most common, certainly, but scratching, burning, even carving words or symbols into their skin, hitting or punching oneself, pinching their skin, pulling out their hair, which, by the way, and whoever can answer, what is the clinical
Uh-oh. Did we lose Don?
We did.
Well, that's okay. That's okay. He'll be back in just a second. He will be back in just a second. I want to get back over to the chat because I think as he left, something happened and he clicked the chat off. So let me get back to the chat. Can you see that? Let's see, audience. Let me pull the chat back up. Give us just 1 second. We are having technical difficulty. There we go. He is back.
There I go. I'm sorry, y'all. I think when I entered the chat room, it just kicked me out for some reason, but I think I'm back. Can you see me okay?
Yes. Yes.
Thank you. Oh, we love those technical issues, don't we? No doubt. No doubt. But look, someone gets extra credit. What is the clinical name for pulling the client who pulls out their hair? Give us the technical clinical term for that. But yes, that is another form of self-harm. And when we mention the term non-suicidal self-injury, that is, as the name implies, you know, these clients are not feeling actively suicidal, but yet they are using self-harm as a maladaptive coping skill to help them deal with whatever issues that they're trying to cope with at this moment. So we'll speak more to that in just a second too. But certainly, we're going to challenge some of the stereotypes and the misunderstandings of what these type of behaviors mean, because they're often misunderstood as attention seeking. And that's not to say that attention seeking does not go along with so many of these clients' clinical presentations, because it does. There are some folks who literally will meet all of the diagnostic criteria for borderline personality disorder, and if you look them up in the DSM-5 text revision, they're sitting there giving you the side eye, and they're like, yeah, they're right there. So they absolutely fit that criteria. So and the attention-seeking aspects of that, certainly, but there really is more to it that I want us to dig a little deeper with today, is because these clients are dealing with deep emotional pain, unresolved trauma, unresolved anxiety, emotional regulation issues, which we'll speak to all that in just a second, especially as it pertains to DBT. And as we know from the clinical documentation and research, early intervention can absolutely be life-saving. I can speak to this personally from my work as a school-based clinician working in the schools in an outpatient outreach program. Certainly, and I know, and working with elementary school kids and on up, is that early intervention is absolutely the key here, no doubt. So what is self-harm addiction? I think it's also important when we say this term addiction, let's even try to look at it through the old school lens of DSM-4 text revision, which October knows that I'm a big fan of, and that any folks here enjoy the old DSM-4 text revision multi-axial format. I'm a huge fan. I just need to know who out there is still standing for DSM-4 text revision multi-axial format. But I really liked how DSM really conceptualize this idea of addiction, because when we talk about addiction, there is always some evidence of tolerance, which you're needing more and more and more of the substance, and in this case, the behavior to get the same desired result. And then also there's this concept of withdrawal, which there is a symptom-specific syndrome of things that the client experiences from stopping the behavior or stopping the substance. In this case, is stopping the behavior. So obviously, self-harm addiction becomes a maladaptive coping mechanism, which when we talk about maladaptive, that means it is harmful, it is hurtful, it is not working for this client. But they utilize these self-injurious behaviors to help them cope with emotional numbness. A lot of times, and if looking at it through the lens of borderline personality disorder again, clients will report that they do feel numb, they do feel empty, they do feel bored quite easily. And so in utilizing self-harm, then it helps them to feel as if they're alive. Seeing the blood flow, for example, feeling the endorphins and the dopamine pumping, when they engage in whatever self-harm behaviors, which we'll speak to that in a second too. But certainly it becomes a bit of a coping skill for these underlying conditions. Certainly feeling overwhelmed is a pretty consistent feeling that I hear clients report to me. The world it can feel very overwhelming right now. Family relationships, school, et cetera, et cetera. I always say for kids and teens, like going through everything they have to experience in their school environments, just that one thing, for example, that is huge and can be very overwhelming, obviously. And also too, as a maladaptive coping mechanism, for shame, of self-punishment, feeling that if clients engage in those type of injurious behaviors, they feel deep shame and guilt, and they want to punish themselves because of that. On the flip side of this, if we're looking at it from even like an operant conditioning standpoint, if you'd like, is that these behaviors become behaviorally reinforcing. So it is that brain reward loop. There is some thinking that engaging in these self-injurious behaviors, kind of operates on those same pleasure centers of the brain, where kind of like for anything else with drugs, alcohol, food, spending money, sex, et cetera, it's like these self-injurious behaviors hit on those same pleasure centers as well, no doubt. And let's go to the next slide, please, October. Which, continuing with this, the brain's role in self-harm here is that, as we just mentioned, that it certainly can release those endorphins, those good feelings, right? The dopamine, which is the neurotransmitter in the brain that's thought to most regulate our mood, which includes depression and any type of mania or any bipolar related symptoms. Dopamine is thought to be the culprit for that. And of course, it's a very temporary release. It's a very temporary fix. It eases distress, but it is very temporary, and that's where that constant loop, that cycle that continues here. And so the relief reinforces the behavior. So it's like, okay, if I'm getting some sort of measure of relief from whatever I'm dealing with, then it does again become that feedback loop where it's like, okay, I engage in these behaviors, it feels good in the moment, but then it doesn't last, and then here we have this cycle of addiction that continues. And I think understanding this, I hope looking at it through an addiction lens is helpful for y'all, because I like to think that this helps clinicians recognize why it's so hard for teens to just stop. I don't know if you as clinicians have heard that from people or have seen this in social media or in working with your clients and families. Folks will just say, oh my gosh, why are they hurting themselves like this? This makes no sense to me. Why can't they just stop? And it is absolutely not that simple, and quite honestly is invalidating for our clients, which we're going to speak about validation here in just a second too. And here's some trends and statistics. Eve's going to give us the numbers here. Let's go, October.
Absolutely. So one, I just want to say before we get started, I love the participation in the chat. There's so many intelligent people in this room right now that are working with patient clients, and your voice is so important. So thank you so much. And for being here, for sharing your insight, and for gathering insight today. Now, one of the things that I like to do is I have a passion for reading self-help books and research studies. I'm real boring, and this is what I like to do with my nights. So
I would never call you boring. What do you mean?
These are some of the trends. I'm not going to read off the slides, but I think you can see the numbers. They're pretty staggering. And what I will say also is research kind of indicates that adolescent males are significantly less likely to report self-harming behaviors than females. And that's just due to gender socialization norms. They discourage kind of emotional vulnerability. And there's also 4 groups that were identified in a study in 2020 that I found really interesting. So I'm going to share it. It's the LGBTQ plus youth, BIPOC teens from religiously conservative families, and teens from immigrant communities. And they experience these kind of cultural stigmas that can inhibit wanting to disclose any kind of emotional stress, especially that being like non-suicidal self-injury. So I think that really speaks to the impact of cultural norms on help-seeking behavior. And I think that some communities might even criminalize, that's a strong word, but to almost criminalize emotional dysregulation. And that leads teens to really control and not always control, but definitely conceal these behaviors to avoid any kind of shame or punishment that's going to go along with them. So, and there's things that clinicians can definitely do to help that, especially since you see the numbers, you know what's going on there. I think that you can create space for teens to express distress in ways that reflect their identity, their language, their values, things like that. I really love, and I know Don does too, these inclusive screening tools and that these open-ended questions to kind of help one, not only foster trust, but to give accurate disclosure. And I was reading something from the APA the other day that I thought, it was a quote from them that I thought was just profound. So I'm going to share it here. The APA says when youth don't see themselves reflected in care they receive, they're less likely to engage in it.
Absolutely.
So.
Absolutely.
All right. Yes. Thank you, Claire. Claire spelled it out. Thank you very much. I was going fast with that, but yes. Great. Thank you, Claire. Thank you. Thank you.
I also would like to acknowledge too, I've seen a couple of comments here that I want to, let's see, hold on. I want to make sure I'm getting this right. Jennifer said, I have one teen tell me she tried cutting and said, that's not for me. I don't want to do that again. And Jordan said the same thing. And that is true. I think that certainly teens are very aware, obviously, of cutting behaviors. It does become, I think, social media is not the cause of all of the ills of society, but it does kind of contribute. I mean, you've seen, I'm sure, and heard about TikTok videos, for example, where folks are on there diagnosing themselves with dissociative identity disorder, diagnosing themselves with borderline personality disorder. Look at me, I've been cutting. Let me share my scars. Let me, and that's the attention-seeking stuff that I think we've touched on. But it is very much within what's social awareness here, within our lexicon, even that kids and teens are very aware of what it means to cut. And I'm so pleased to hear that, well, in these two cases, it sounds like, they tried it. They found that it was not helpful. And I'd like to hope that maybe they found other more constructive things and to really help them navigate those struggles. So moving on, what we got next? I think it's important for us to look at, too, the risk factors and underlying causes for some of these behaviors. Obviously, a trauma history or any abuse history can contribute to this. And anytime we talk about trauma or abuse, it's physical, emotional, mental, sexual, it encompasses so much. And I think that what we have seen, especially with like depression, anxiety, some of the personality disorders, I keep going back to borderline personality disorder, but that is a very common diagnosis, not always, but very common diagnosis for folks who present or engage with some of these kind of behaviors. And there is some sort of trauma or abuse history related to that. Also, to just the academic pressures that our kids have to face nowadays, this concept of perfectionism, this focus on being perfect. I always like to say there is no such thing as perfection. Perfection's an illusion. We can strive for excellence, not perfection. And I use that a lot as a mantra for some of my clients that I work with, because we can be quite excellent, but we are absolutely not perfect. And I think if any of you are aware of your clients in whatever school setting, whether it's elementary, middle, or high school, especially high school, the amount of pressure that these kids have to face today, it's just so high. And it is based off of numbers and GPA and all of the expectations, sometimes unrealistic expectations that we sometimes place on our kids and teens too. And so obviously identity struggles play a role here, in coming to grips with one's gender or one's sexuality. That is a process for everyone. Everyone handles that differently. And I think that, that we do see more of that start to present itself during this time period. But also, too, we start seeing more and more symptoms of depression, anxiety, borderline personality disorder during this time. And also, as a result of their environmental struggles and all the environmental factors that play a role here, peer dynamics or bullying is such a powerful thing, and unfortunately still a very relevant thing, especially when it comes to social media and how callously cruel folks can be when they're sitting behind a computer screen. We can talk more about that later if you'd like, but I think that sort of speaks for itself, unfortunately. And on to the next slide. So some of the common warning signs, which you guys, I'm sure have seen with some of your clients before, is wearing long sleeves, even in warm weather. And that is generally to hide any scarring or any scratches or anything that that the client wants to not share with anyone. They want to keep it to themselves, and they sometimes isolate and keep things quite secret from folks. And, certainly, too, they have access, obviously, to sharp objects, and those sharp objects are either hidden or missing, or they have them on their person. And certainly that is a huge concern. And I don't know if anyone's ever worked in the schools or any of those mental health settings, as you know, that they will eventually be found, and hopefully by the staff or teachers or clinicians. And it's definitely, that could be used. The silver lining to that, I think, that could be used as a platform to have an open, honest discussion about what this means for them. Unexplained cuts, burns, bruising, also too sudden emotional outbursts or even numbing. Like we said earlier, some clients will report feeling numb, feeling bored, feeling empty inside, and that can absolutely be a challenge that we as clinicians face, because we want to help them find ways to be open and honest and vulnerable, and to feel things again, which we'll speak more about that in just a second too. Now we do have there are a variety, as y'all know, there are a variety of different screening tools out there. I think there's the deliberate self-harm inventory, the DSHI. There's the ISAS. Y'all know there's an acronym for everything we do in mental health. How many acronyms are there? No doubt. But the inventory of statements about self-injury, and the CSSRS, the Columbia Suicide Severity Rating Scale. There are a variety of different things that you can utilize to really try to make sure you're doing a comprehensive evaluation of our clients' feelings of suicidality and in this case, self-harm. I like to use the deliberate self-harm inventory. It is a pretty straightforward tool that we can use to assess for this. It's a 17-question yes or no answer self-report questionnaire that really explores these self-harming behaviors, such as, I'm reading off the list here. Have you cut yourself on purpose? Have you burned yourself on purpose? Have you hit yourself? Have you driven recklessly on purpose? Have you prevented wounds from healing? Have you set yourself up in a relationship to be rejected? That's an emotional self-harm here too, which we can speak more to that in just a second as well. So hold that thought. But lost a job on purpose, engaged in sexually abusive relationships. So do you see that any kind of self-injurious behavior extends far beyond the stereotypical cutting behaviors that we tend to refer to with this population? And let's check out the next slide. All right, so obviously this is the cycle of self-harm and addiction. So, and obviously it repeats itself. So a client experiences emotional distress, whatever that is, and that, of course, as clinicians, that is something we can absolutely evaluate and assess too. Then there is the urge to self-harm in whatever ways that they've chosen, and there is that temporary relief. Remember, they do get a bit of a fix if you want to look at it that way, and there is some sort of positive benefit, but it is temporary. It does not last forever. And then we end here with the shame and the secrecy of it all. This is where we see more of that guilt creeping in, and that really, that internalized self-hatred that I think we talk about a lot with our clients too, which really, in terms of their self-esteem and their self-image and self-worth, we really do see how this impacts their overall level of functioning in so many different ways. So what happens when teens try to stop these behaviors? Again, if we're looking at it through the addiction lens, we've talked about tolerance, where you need more and more of it to get the same effect. And we can also look at it as through a withdrawal perspective too. Like when we look at withdrawal, it is, as we've said, a symptom-specific syndrome of symptoms where it really causes our clients extreme distress. So common withdrawal, if you want to look at it this way, common withdrawal symptoms include that agitation, that anger, this dysphoric mood, which dysphoric is literally angry, irritable, sad, crying. I mean, it encompasses so many things. They experience the urges still, certainly. And then along with that, that sadness, that anxiety. These are some of those common with emotional symptoms and behavioral symptoms that our clients experience as through that withdrawal lens. Now, the support here, and we'll speak more to this in just a second when we look at interventions, but the support here includes distress tolerance. And if anyone is familiar with DBT, you know, distress tolerance is a huge part of that program. And replacement behaviors, trying to find healthier coping mechanisms to help folks navigate these type of struggles that they're dealing with. You know, it's like we talked about, you know, self-injurious behaviors becoming this maladaptive coping skill. Well, let's try to explore with our clients some helpful coping mechanisms that can get them those natural good feeling hormones that we were talking about with the endorphins and with dopamine. Let's try to help them find healthy behaviors and healthy activities that they can engage in. And you know this as clinicians, you know, we always try to track the triggers. We try to look at what has set these thoughts and feelings and behaviors, the cognitive behavioral model, as you know, what has set these thoughts and feelings and behaviors into motion. And certainly, if we look at programs like DBT, you know, there is the behavioral chain analysis where we look at from beginning to end what set off this chain of events, and let's explore it and process it and try to figure it out. And obviously, teens may feel worse before they feel better. I don't know what y'all think about this. I'd love your feedback, but usually when I meet with my clients, depression, anxiety, you know, the self-injurious behaviors, any of these type of things, I always talk about realistic expectations. And I always tell them that let's have some realistic expectations that this is going to hurt before it feels better. It's kind of like if we break our arm, right? You break your arm, it's going to hurt for a long while before it heals. That's how I like to explain the expectations of therapy, because I think they've got to have some realistic expectations of themselves and of their therapist, that these things that has led them to this point, they've not happened overnight, and they're absolutely not going to fix themselves overnight. So let's please focus on, and maybe even some good advice for you therapists out there, let's please focus on having some realistic expectations of yourselves too, because these clients, they often present with their set of clinical challenges, as we know, and let's have some realistic expectations of ourselves as far as helpers for what we can do to help.
Absolutely. One thing I wanted to add in, if I could, Don,
Absolutely.
is, and I don't want to thank everybody because everybody is having a lot of personal contributions in the chat. And I think
Yes.
this kind of just reflects how complex and layered self-harm can be. You know, it's because you've got folks talking about trauma histories. I see a neurodivergent, family dynamics, cultural expectation, faith, guilt.
Yes.
Struggle for emotional regulation is what I'm seeing in the chat. And so each one of these folks carries like a very unique story. And then whether it's like trying to hide the scars, you know, with hoodies or just openly displaying them, like all these behaviors are really, really powerful forms of communication. And so these insights that I'm seeing in the chat right now, I keep looking on the left-hand side. That's where the chat is on my screen.
Yes.
But it really hones in that the treatment has to be individualized, right? It has to be trauma informed. It has to be compassionate. It has to be collaborative. And so I just want to thank everybody in the chat for kind of like for showing up for your clients and showing up for each other.
Absolutely. Absolutely.
And
I've seen some comments. I'm sorry, October, I didn't mean to cut you off, but I've seen some comments too about other treatment modalities. And thank you for saying that. Like EMDR, for example. Oh my goodness. Thank you, Francine Shapiro. We love Francine Shapiro. EMDR, eye movement desensitization reprocessing. It's such a very, very important and effective way, especially to treat trauma and any unresolved trauma. So yes, EMDR is we could do a whole webinar on that one, obviously. That might be a good idea for later, October. But certainly there are many other interventions. We'll talk more about the interventions in just a second, but there are so many different treatment modalities that can be so helpful for these clinical issues we're dealing with.
Absolutely. Well, and someone asked a question that I think was really important, like, and I can't remember the exact question. I'm scrolling through this to try to find, is there a strong connection with suicide and cutting? and what is the percentage of children that self-harm, attempt suicide. And so I did have some studies in that. I didn't throw them in the slides, but I do want to talk
Mhm.
about it. There
Sure,
is
please.
a real significant overlap between the two,
Mhm.
especially in adolescents. So I think we need to be really clear about that. But the CDC in 2022 said that youths who engage in self-harm are 3 times likely to attempt suicide compared to those
Mhm.
adults. 3 times. That's a lot.
Mhm.
And then JAMA did something in 2021. And it said 1 in 4 adolescents who engage in that type of behavior will attempt suicide, and about 70% have experienced suicidal thoughts.
Yes.
So I think that we're seeing that that does put those youth in, I think it's a strong predictor of future suicide attempts. And I think it puts them in a higher risk
Mhm.
when you're looking at the data.
Absolutely. Absolutely. And thank you for sharing those numbers, because I think it really does help really make our case here that this is such an important area we need to focus on in our clinical work with our clients.
Absolutely.
Oh, this is we talk about all the things of what to do, which we're going to get to that in just a second. But I think as equally important, I think it's what not to do as a caregiver or a clinician. Um, and I think this goes without saying, but please, 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 don't minimize their pain. Don't say, oh, it's just a phase. Oh, you'll get over it. It's like, oh, you're just a teenager. This is just what teenagers do. No, 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 no. Nope, nope, nope. Let's please not do that. Don't minimize what they're experiencing, because really it is so invalidating. And and I've talked about DBT and Marsha Linehan. I'm a big fan, by the way. And so much of her work, her cornerstone part of her the cornerstone of her work was validation, like the acknowledgement, like I see you, I hear you, I'm with you. And it's like, if we say things like, oh, it's just a phase, or oh, it's no big deal, or oh, or even saying, oh my God, stop doing that, because what is I think we want to help people. Obviously, we want to save lives. Obviously, we do it every day. And I think sometimes, tell me if I'm wrong, but I think sometimes the tendency is to say things like that, like, oh my gosh, why are you doing that? Stop doing that. You're going to kill yourself. And it's like, so much of that I think can be invalidating too, because yes, I mean, it is difficult to talk about suicidality. Yes, well, let's just be honest. It's very difficult for your clients to talk about it too. It's very hard, especially for kids, to talk about and openly engage in a conversation about these self-injurious behaviors that we're discussing. And so by saying, oh my God, don't do that, it's really, I think, so invalidating to them. So I'd love to hear your feedback on this, but every time I talk to any of my clients about this, I always validate their feelings. Like, you have every right to feel the way you do, and you have every right to feel that overwhelmed with everything. You have every right to feel every single thing that you're feeling. But as we know, it's what you do with those feelings that are most important. I've even had conversations with folks. This may be a little controversial, but I've even had conversations with some of my folks who were feeling suicidal, actively suicidal, had a plan. I mean, the whole thing. And I said, you know what? You have every right to feel that way. Your feelings are valid. There are things that have contributed to you feeling this way. You have had experiences that contribute to these emotions, and you have every right to feel them. Now, let's please don't do it. I mean, certainly we want to keep you here with us. You are valid. You are important. We need you here with us as long as we can. But, certainly your feelings are valid about that. So I'd love to hear your feedback. Some people agree with that, some people not so much. So I'd love to hear your feedback on that. And because that could be a little controversial, but I think certainly validation is so very important here. And of course, avoiding the punishment or shame. Let's don't try to shame our clients in these behaviors, because again, there are reasons why they're doing those. And there are reasons that far extend even the attention seeking stuff that we talk about. But even the attention seeking stuff is an area of clinical attention that we need to focus on too. I always talk to my clients about, okay, if you are seeking attention, let's figure out some ways to get some positive attention instead of that more negative attention. We can speak to that later too. But never take away their coping tools without replacing them, because, I've talked to clients before that if we're looking at this through an addiction lens, it really has become such a comfort for them. It's as maladaptive as it is, it truly has become such a comfort for them. And so, we can't just say, all right, you got to stop it altogether right now. Let's work on a plan of action on how to, because abstinence, if we're looking at it through that lens, abstinence is effective in some things, maybe not as effective in others. So let's don't take away the tools without giving them some workable, adequate replacements. And don't focus solely on the behavior. We show, we'll talk more about this with DBT, but Linehan talks about how we show acceptance of the client, not the client's behavior. Just because they make bad choices doesn't make them bad people. That's been one of my mantras too in working with clients over all this time. Like, look, we all make bad choices. That does not make us bad folks, no doubt. Sorry, I got on a soapbox there. I just had to throw that out there.
Love it.
So what to do instead? Now, certainly validate. Like, hey, you guys know how to do this. I know you do. Give us some examples of how you validate your clients' feelings. Like I always say, hey, gosh, that sounds like that's so hard for you. That sounds like that is so difficult. I'm here with you. I see you. I hear you. This is a safe space. You have every right to feel the way you do. Those are some of the things I say to help validate my clients' feelings. But please give us some examples of how you validate your clients' feelings. No doubt. Asking open-ended, gentle questions. Yeah, I'm a fan of gentle. Sometimes we could be a little more assertive, and we could, set some boundaries where we need to with our clients. But I do tend to be more of the asking the gentle questions. Being open-ended too. Sometimes, as we were talking about with the inventories a little bit ago, sometimes we can have yes or no questions can be great. Those closed-ended questions can be very helpful. But if you are trying to explore what is going on with your clients right now, let's don't ask those yes or no questions. Let's ask those more open-ended questions. What was going on with you? What were some of your thoughts and feelings that led to you engaging in some of these self-injurious behaviors? What were some of the triggers, et cetera, et cetera, et cetera? The what and the how questions I am a huge fan of. I'd love your feedback on this too. I'm not necessarily a fan of the why questions. Why, I used to tell my students this and they look at me a little cross-eyed, but why questions sound very accusatory. Like, why did you cut yourself? Why did you do that? Why did you do this? The why questions tend to be a little accusatory, I think. So let's kind of try to use them sparingly. But I would love your feedback on that. Please give some honest feedback on that as well, too, if you get a chance. But involving them in building a personalized safety plan. That is so very important too, because again, if we're being person-centered, and we are person-centered, all of us, right? If we're being person-centered, it's not just a one-size-fits-all type of approach here to care. And especially when we're talking about safety planning, that is a big deal. And safety planning, I mean, and I know you guys are familiar with this, safety planning really is coming up with if you really want to look at it this way, we used to refer to it as a safety contract, but we've since changed the terminology to safety plan. But it is kind of the same thing. You are constructing a plan of action with your clients that can really help them navigate these type of situations and to help them when you're not always available. And quite honestly, we're not always available. So, that's where we have to really come up with a concrete, specific plan of action to help them navigate these type of very difficult situations, which, as you know, and October is going to talk more about iNotes because they have safety plan included into the platform. But, just in general for safety planning, what are some of the warning signs that you're beginning to have a struggle? What are some of the coping skills that you can use to help you navigate those difficult situations? What is your list of social supports, your natural social supports that you can utilize when you're having a crisis? And also, too, knowing, I would encourage, y'all probably know this already, but I would also encourage you to familiarize yourself with local emergency support services. What are, of course, 911, you know this, but what are some of the other agencies or other hospital systems. Charlotte is very fortunate to have Atrium Healthcare's. I think Eve, tell me if I'm wrong, but I think it is still very much the only psychiatric emergency room here in this area. And
Yeah,
it is
there's
the site. Mm-hmm.
yeah, there's some psych suites, but it as far as it is a full emergency room just for psychiatric care. So
Absolutely. So please, and they have a 24-hour crisis line, this staff 24/7, for example. So please familiarize yourself with some of the more localized support services, because again, realistic expectations, you're not always going to be available for your clients. So we have to make sure that when you aren't, that they've got resources that can help them navigate emergencies. And there's also there's 988 as well. There's the National Suicide Hotline and support. There are many different resources that can be very helpful in helping folks navigate emergencies.
And I want to say, up in the handouts, we have our slides, but we also have a safety plan up there in the handouts. And in our safety plan and iNotes, I put a bunch of numbers in there. 988, there's a crisis text line.
Yes.
There's the National Domestic Violence line. There's the National Sexual Assault Hotline, the Trevor Project, the Veterans Crisis Line, substance abuse lines like the SAMHSA helpline, NAMI, all of that is in there on that treatment plan. So if you're interested in that, treatment plan, safety plan. It is a treatment plan, but it's a safety.
Yeah, absolutely. Oh, I love NAMI. Thank you for including NAMI. I'm a fan. NAMI, the National Alliance on Mental Illness. I'm a big fan. Seriously, they do some good work. So yes, please. All right, let's check out the next slide. And I know we're running a little low on time, so I'm trying not to run my mouth for too long about this. But obviously, I told you I'm a huge fan of dialectical behavior therapy. Thank you, Marsha Linehan. She was the psychologist who developed dialectical behavior therapy in the 90s. And it really was initiated as a treatment response for helping folks living with borderline personality disorder. But thankfully, we have found out that since then, it's really helpful for such a variety of different things. I mean, pretty much every client I work with, I am cherry picking some sort of DBT related exercises and techniques that I think are very helpful. And that's the good thing, I think, about us as mental health therapists, is that we can cherry pick the types of approaches that we find useful and effective with our clients and what we feel comfortable with. So DBT, as the numbers are showing, it helps reduce self-harm by up to 77% in adolescents. It works. Now, it's hard. It's very difficult. It's a very structured, organized program. If you're doing DBT the Marsha Linehan way, then absolutely you get certified. You do more than just a 2-day training. A lot of folks will do a 2-day training on DBT and say, "Oh, hey, I'm a DBT therapist." Yeah, no, you're not. And it is a process very much like almost like the supervision process to get your licensure for whatever profession you're working in. It is very much like that. It's very detailed, very structured, a lot of work, but it's so very vital in helping our clients navigate their emotional struggles that they're dealing with. DBT also is broken up into 4 different components. There's the mindfulness component, the distress tolerance component, the emotional regulation component, and the interpersonal effectiveness component. So it's like, if you guys are interested in future webinars on DBT or anything else that we've talked about today, please let us know in the comments too, because we certainly don't have time to take a deeper dive into that, but definitely would love to do it at some point in the future if you guys are interested. Certainly, mentalization-based treatment, MBT, is effective in reducing self-injury in teens with emotional regulation. It utilizes a lot of visualization techniques that help our clients navigate these type of behaviors and feelings. Cognitive behavioral therapy, or CBT, it helps to decrease suicidal ideation and any of these non-suicidal self-harming behaviors over time as well. Now, there's a little bit of a difference between CBT and DBT. CBT, of course, focuses on all of our thoughts and feelings and how they influence our behaviors. DBT is all of that too, but Marsha Linehan does a lot of the like Buddha-esque, Buddhism type Zen type of of interventions like mindfulness, being aware of the present moment, being non-judgmental, which is so very important. And so, so she does kind of spice it up a little bit in her very structured program. Family-based therapy it certainly demonstrates improved outcomes when we look at the family dynamics and such. Now, we talk about internal family systems, which you guys are probably aware of too, where we're focusing on parts work there, healing your inner child, healing those wounded inner parts. Those can be very helpful. And I think, October, I'm already on the next slide. If we can go to the next one. Thank you. But I'm also a fan too of structural family therapy. Are there any I'm just curious, are there any Salvador Minuchin fans here in the audience today? Because October knows I'm a big Salvador Minuchin fan. Minuchin pushed this idea of setting boundaries, focusing on how the family is set up, what are the roles of the family, helping folks learn how to set boundaries. And I think in this case is so very important in that, giving yourself permission to tell your family members what it is that you want and need from them, basically talking about realistic expectations. So I'm a fan of structural family therapy. Salvador Minuchin, look him up. He's got some great stuff going on as well. So family therapy is so very important, and supporting the support system. Now, we as therapists, we're also educators. So, I think that psychoeducation is so very important. And again, challenging some of the stigmas associated with this non-suicidal self-harm behaviors is that, just because someone engages in cutting behaviors or just because someone is harming themselves in whatever way, that does not automatically qualify them for a borderline personality diagnosis, for example. So let's please remember that we've also got to challenge the stigma associated with these behaviors and the stigma in general associated with mental health and mental illness. Avoiding blame, we talked about that, absolutely. Support open communication and active listening, having a dialogue, being able to have an honest dialogue, and with active listening, helping other folks understand and helping them see that you are indeed listening to them and that you are aligned with them and you have that therapeutic alliance, as we say. And teaching the caregivers how to manage their own emotions first. I think this gets to a lot of self-care related things. And I think for us as therapists, it's so very important for us to utilize let me use this as a platform for the self-care stuff. I think it's important for us as therapists to utilize self-care as well, because these can be very challenging clients. This is a very challenging population to work with, and we need our own sources of support and self-care as well. And I think we've kind of sort of touched on some of this before, but and again, in the spirit of trying to keep us on time here, I'm going to rush a little bit. Self-harm versus suicidal behavior. Self-harm is a coping strategy to stay alive. Suicidal behavior is a desire to die. Self-harm, usually not lethal. But suicidal behavior obviously can be lethal. Now, I will say too, with the non-suicidal self-injurious behaviors that we're talking about here, certainly even it is obviously an area of concern, because I think that, let's say, for example, you have a client who's engaging in cutting behaviors, but they may not necessarily have the intention or the desire to end their lives. But sometimes they can, let's just keep it real. And October, you're the nurse here, so please chime in. But let's keep it real. Sometimes they can cut too deep and by accident. And that's what makes this so much of a huge clinical concern for us, is because even without wanting to die, sometimes that does happen. So we have to be very mindful of that too. This is, as you know, something very, very serious. Self-harm is repetitive and self-soothing. Remember, we're using it as clients are using this as a maladaptive coping skill. Suicidal behavior is usually crisis-driven, and that's where, of course, we also have safety planning in place too as a crisis intervention technique. And I'll let October speak to this part.
October, you're on mute.
Thank you very much for catching that. So sorry. What I was saying is there's so many good questions in the chat. I wish we had time to answer them all. There was one that I believe it was Nora asked, and it says, is there any research on how young adults who have stopped self-injury deal with their scars or living with their scars? There is a research study, and listen, I wish that I had really, really great news for you. Like, oh, it was great, but it's not. There was a study done in 2020, it was in 2020, and it was 70% of youths who have had self-injured or they have scars, they feel shame and stigma, especially in early recovery, especially when they're in the workplace or professional social settings. 40% said that they concealed their scars, and then 30% said that they actually had self-acceptance of their scars, and they, like, I don't want to say it was their survival, there was resilience that showed, and then 15% actually felt empowered. So I'm really happy for the 15% and even the 30% that are working towards it. But I think you should just know the rest of the numbers don't look really good. And I hate when research shows those kind of things, but I think we have to be honest and talk about it.
Yeah.
The next thing I want to talk about is legally reporting self-harm, like what you need to do. As you know, I'm the Chief Clinical Officer with iNotes. I am very heavy into compliance. I used to work for a law firm that protected clinicians. So there are a couple things I'm going to say about this as far as what you need to know. And I want to be really clear about it. It always depends on your state laws, okay, and whether the behavior is considered life-threatening. But I do need you to know that courts have not been kind to clinicians or even institutions when there are serious concerns like self-harm and they weren't disclosed to like parents or guardians. That is the truth of the matter, in especially in situations where harm escalated. So whenever you are in doubt, you need to get with a supervisor. It could be the part that you get with legal counsel. And a lot of people will say, and Don, we may disagree on this, but they will say, I work with a client that, you know, that adolescent or teen is who I work with. And I am very protective over that. And I am going to tell you, and this is from the legal aspect, okay? This is not the touchy-feely feel-good part, all right? This is your license is your livelihood. And I know that you care deeply for each client, but you have to protect your ability to continue helping others. You don't risk your entire career or your license for one case if that means you can't serve the needs of other individuals. And so when there's those kind of safety or legal concerns, I know how people feel like, well, I have a professional or ethical obligation. You make sure that you consult with someone who can really assist with that. Do not put it all on the line to help one client. Unfortunately, I've seen that happen. It never ends well.
Mm-hmm. Yes. Oh, I totally agree with that. No, we're very much on the same page. I'm a huge fan of helping our clients. This is a very Marshall Linehan thing to say too. I'm a huge fan of helping our clients, but I'm also a huge fan of making sure you're taking good care of yourselves as well. And if and things vary, and October's absolutely right. I think things vary, laws vary in different states. I think familiarize yourself with what is going on in your own state. And I always say that when in doubt, you can always refer to your licensing board, NASW. I'm a clinical social worker, and NASW is very helpful with giving us feedback. And also, too, remember, I'd like to hope you all have some form of professional liability insurance. And guess what? Let's utilize that as a resource, too. If you have any potential questions about these type of legal issues, you can absolutely consult with your professional liability insurance as well. I'm just throwing that out there.
Absolutely. Well, I think one of the last things that we want to cover is documenting this in the EHR. I love verbatim quotes. Verbatim quotes tell a story. That's really, really important to use these kind of verbatim statements. And you want to talk about their appearance, their behavior, the disclosures that they have, any kind of risk assessments, safety plans. Really good question about should safety plans be signed. They don't have to be. Look, would I go that extra step and get them signed? Yes, but they don't have to be. But a really good question. And any kind of parent communication, document all the communication that you have with the parents, because parents they'll inadvertently come back and be like, oh, I didn't know. And then that you are then on the hook for that. So absolutely. And then I will show you, I am going to just go and run through iNotes really quickly, and then we're going to answer some questions really quickly. Let me just share my screen here. And I just want to show you iNotes. That is our kind of our sponsor for today. And I'll show you a little bit about what iNotes can do. And also, one of the great things is communication in the new iNotes Plus. So if you're able to see my screen here, this is iNotes Plus. I can run into any patient's chart like Kyle Smith, and I can go to the communications tab here, and then I can go in and initiate a client portal, and then I can start to send them forms via this client portal, like forms and assessments. You can set these up, which assessments, or we set them up for you, which ones you want to send. All right, you're able to do that. You're able to even send packages, like maybe it's an intake package, and I can send that immediately to the client. iNotes Plus, you can do online scheduling within it, and then you can absolutely do notes within the system as well. So I can go in and really quick, we have all kinds of different notes, clinical summaries, we have our forms and assessments, have the ASAM case management notes. We have EMDR notes in here, but here's our SOAP note. I can run into that really quickly and talk about symptoms that are reported. Like, is it depression? Are they self-harming? Are they feeling helpless? Things like that. Here, I can talk about current stressors, like problems in school and problems with relationships. I can do the objective, like their behavior. Maybe there's symptoms observed, but their self-care is just, they're dependent. Their substance use is more than advised. They're having anger. It's poorly controlled. Their impulses are poorly controlled. I can go into the assessment here, and I can look at rating scales if they've already done that. It gives me a normal MSE if I want, and I can even link the treatment plan in and just bring the treatment plan in as well to this note. So I'm able to do all of that and then have a nice finished note. We are going to start utilizing AI in the future. We're really excited about that, but you can see that iNotes helps you create your notes very quickly and easily in the system. So that is all. Listen, we appreciate you so much for being here today. And we're sorry we weren't able to answer all your questions, but you guys had such good ones.
Yes, indeed. Thank you for the feedback. Good gracious. And yes, please let us know too what you'd be interested in for future webinars. October and I have talked about doing some more work together. We're very excited about that. So let us know whatever we've mentioned today or anything that we didn't mention. Maybe we can start working on some of those things for the future. No doubt. But I just want to say thanks to all the helpers out there. Thank you all for all of the good work that you're doing. Let me throw some validation your way, because look, it is hard. What we do for a living, it's hard. And so thank you for all the good work that you're doing. And I always like to say, let's keep hope alive in 2025. That's exactly what we're going to do. And y'all, please keep up the good work out there, because again, you may never know. It might be that one thing that you say or do that really makes all the difference for your clients. So thank you. All right. And I'm getting off my soapbox. Y'all have a great day.
See you. Thank you.
Thank you. Y'all take care.
Bye-bye.